Welcome to the Codecast podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello, everyone, and welcome to the Codecast podcast. Today, my name is Terry Fletcher. So I know you're probably tired of hearing about telehealth, but because there's so much confusion and I've taken a couple of positions on the audio only, I thought it was only appropriate here on hashtag Terry Tuesday, January 14th, to clarify a position. And actually, I'm backtracking a little bit. I'm not in agreement with what CMS is doing or some of the other payers, but I do have to give you the information and then give you probably my best practices on how to handle audio only. So first of all, going back to what we ended up with at the end of 2024 was that we lost 99441 to 443 audio only. The Medicare and many of the third-party payers, just like Anthem, United Healthcare, Aetna, Blue Cross Blue Shield of North Dakota, they've all said they're not going to recognize the new telehealth codes, which have audio only and audio and video. And so the question comes up, can we bill office visits with a 93 modifier? Well, I don't like it, but unfortunately the final rule, which actually specified that it was appropriate if it is for mental health, substance abuse disorder, and end-stage renal disease clinical assessments, yes, you could do that. But then if you read further in the final rule and then transfer it to page 97,700 and I think it's 60 and 61 of the Federal Register, then you notice that they're also saying that you can, but there's always these under certain conditions, and you have to make sure you know the certain conditions. So it is if the patient is in their home, they don't have access to or does not wish to use two-way audio and video, and it will improve their care. And they also said, particularly for rural and underserved populations, they would deem that could be appropriate. Again, the physician has to make sure that it is appropriate and a general expectation for telehealth that the patient can be evaluated over audio only, which isn't always the case. And they're very clear on Medicare telehealth services. They said they're analogous to and must include elements of the in-person service. This is right on page 97,761 of the Federal Register. They said, we continue to believe that the use of two-way real-time audio and video communication technology to furnish Medicare telehealth services is the closest approximation to an in-person visit and is an appropriate general expectation when furnishing Medicare telehealth service. And that's right under Federal Register 410.78A3. Now, they talk about audio only, and they are very specific to interactive audio and video communications that the physician still has to have, the one at the distant site, which means the one that's treating the patient at the time, they still have to have capability for audio and video. But here's the thing I notice all throughout any of the published guidance when it comes to telehealth audio only. Basically, they're saying that it is really patient-generated, meaning that if the patient is the one that is saying, they even call it a policy that would permit a patient-driven choice. And I think that's an important distinction there when it comes to audio only. To use audio only technology to receive a Medicare telehealth service based on their technological capabilities and limitations and their comfort level with the use of video technology in their home. They're really gearing this toward the much older patient that has maybe some challenges with video and audio and video, or maybe doesn't have the broadband, or maybe just, has a problem using it or being on camera. But when they talk about those challenges, they also go back and talk about mental and behavioral health. And after they considered the public comments, they said, okay, we're going to allow it, but at a minimum, audio and video equipment permitting two-way real-time interactive communication between the distant site provider and the patient, again, the provider who's seeing the patient over the airwaves, is capable of having that audio and video. So it's not like you can have your own practice of just telephone calls. It says, and then it also keeps going on. It said this 5 different times in the Federal Register, and I'm quoting, but the patient is not capable of or does not consent to the use of video technology. And then you'd have to use the 93 modifier, and you still have that place of service 02, or I'm sorry, 10 for the patient's home. 02 is for a facility. But here's where my issue with it. And again, I'm going to caution you by even doing audio only. First of all, there's more guidance when it comes to the specific diagnosis it allows, and it does follow behavioral health, mental health, substance abuse disorder, and also looking at end-stage renal disease. But it does go on to say and give some generic sites that says, yes, you can probably do that for patients without that diagnosis, but it keeps saying under certain circumstances, in limited exceptions. And so it says to reflect this limited exception to address the unique considerations of patients. So when they say that, it's not routine. You have to make sure that you have documented those limited exceptions. You have to make sure that, and they talk about special considerations. That some of the examples that they put in there is they said, our purpose was to recognize that while real-time interactive audio and video remains the generally acceptable or applicable standard, there are special considerations for patients when a Medicare telehealth visit service is delivered to their home, and they give certain examples. They basically have said that here's one. Where is it here? It says, for example, a patient may not have sufficient or any access to broadband to support the use of real-time video technology. So if they don't have Starlink, the Elon Musk situation, which is very inexpensive, and I wish the government would have provided that. But if they don't have it, if they're rural, live in the mountains or live in an area that doesn't have that technology that is strong enough to get video, then they understand that. Or if they don't have, they call it if they may not have the technical proficiency, so they don't understand how to connect to video, or the support in place to use video technology, or privacy concerns about using video technology, or somebody to see, their home or their background. But remember that there's a reason that the doctor's office, in person is important. It's what you can see in person. It's what you can evaluate in person. It's to see somebody get up out of a chair, to see a face droop, to evaluate a rash that could actually be connected to maybe a lymphoma, palpated mass that you cannot do via technology and via virtual. And so when they talk about these, exceptions, they say, there are certain, and this is one thing that I noticed. It says we limit our proposal using under the narrow circumstances when it comes to the audio only. And so this is not routine. So you would have to document, why does your patient today need to have audio only? And there are also many Medicaid situations out there. I know in California we have it that every single audio only has to be individually consented to. Audio and video, not so much. You have to have it once a year, but audio and video, audio only, every single one. And so they're looking to possibly permanently change this, but they're first looking to see if this is truly patient initiated. Do you have the equipment, but the patient's not capable of consent to, or there's a problem? And so that's where you have to make sure that you can support. And it's not to give test results. It's not to just call the patient to check in on them. We're going to have a lot of bad actors here, people, and I hope you're not one of them. I can't support audio only when we're not in the height of a pandemic. We're 2 years out of the end of the pandemic. We are 5 years out of the beginning of the height of it. And so at this point, it's time to move on, get patients back in the office, allow for audio and video if it's appropriate, and in rare exceptions, use the audio only. And, I'm sticking to that. So that's where I'm at with it. If you choose to go down a different path, that's entirely up to you, but you're under your own risk there. I can't support it. It's an exception to the rule. So I also talked about this on a hashtag Terry Tuesday episode with the compliance guy with Sean Weiss that we also have on Tuesdays. And I'm going to update my website on my blog. I know right now I have something up there from last year in December when they updated the continuing resolution to give us that 90-day extension. But the last thing I'm going to say is, remember, we have new sheriffs coming into town. We have a potentially new HHS secretary has to get confirmed, Robert F. Kennedy Jr., and he is very litigious. And he is very much about saving money, making sure that if the money is going to be spent on healthcare, that it's going to be appropriate. We have a new potentially new physician coming in, Dr. Oz, for CMS as the administrator. He's also going to have input on telehealth. So please, let's try to make sure we understand the bottom line here is what's best for the patient. What is your clinical judgment that you can support? And try not to focus so much on audio only unless it's absolutely necessary. Okay, personal tidbit. Yeah, my Steelers are out of the playoffs. We absolutely laid an egg in the last 5 games. It was terrible. We lost 5 games in a row. We ended up with 10-7, and then we lost the first wild card game, which I wasn't surprised playing the Ravens, but it is what it is. So now I'm probably watching by myself because my husband is not happy, and so then he's kind of done with football if his team's out. He pouts. So I'm a football fan, so I'll watch it. But anyway, also for those of you that asked, I am in the Southern California area with the fires. It's not great here. We do have some winds still continuing even this week. I'm about 60 miles away. I was about 68 miles away. I'm hoping they're not going to move too much closer. But as I'm talking to you and recording, I actually had to close my window because I can smell smoke, which isn't a good thing. So it's definitely affecting a lot of us. So anyway, anybody in the Los Angeles area that listens to our podcast, please stay safe. And make sure that if anyone wants to give money, I would recommend the SamaritanPurse.org. That's who I give to. I've given to them 4 times for North Carolina and for the fire zone. And just whenever I see a need, it's a religious organization that is just out there to help. And 89% of their proceeds go directly to the people. I've seen them out there. I've met them, and it's not a corporation that pretends to give money. So that's who I would give to, or give, if you're giving to the fire zone, give to the local fire station, or if you are on the East Coast, you want to give to the local churches, and you'll know that your donation and your input is definitely getting to the right people. All right, everyone, make it a great rest of your week. Make it a great day. And thank you for listening to the Codecast podcast.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter @TerryCoder1 or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.